So I want to wrap up just with the getting started, kind of going back to the beginning after this journey we've been on the last couple days, and kind of what are the nuts and bolts of getting started with BDP if you want to try using that with one of your clients. So you should be pretty familiar with this slide by now, and so how do we start to do that? How do we get to stage one? Stage one, can I be safe here? We're trying to build autonomous motivation. Autonomous motivation means the person decides that they want to be in treatment for themselves, not because their spouse wants them to do it, not because their therapist wants them to do it, but because they actually want to be there. And autonomous motivation, recent research is indicating, is one of the best indicators for a positive outcome in many different kinds of treatment, not just DDP. So really getting that going is very important. Of course, autonomous motivation is very closely related to what we talked about last time, individuated relatedness, being their own person in a relationship, having their own opinions. And one opinion is, do I want to be in treatment or not? And at the same time, you want to develop a soothing attachment. You want them to feel connected, feel bonded with you, and to start having some of their distress relieved. So this is just a summary. It's also in the manual, by the way, establishing the frame. What I'm going to be talking about is in the manual under that chapter. So, but session, and this comes right from the manual. Session one, you're just gathering the history. We'll talk about what history is most helpful to gather in particular. And then you want to formulate or reframe their problem in a way so you can both be on the same page as to what the goals and the tasks are of the treatment. So you can both agree on that. And then you do want to ask whether the client wants to do this, whether they want to give it a try. So again, you're the backseat driver. It's up to them whether to decide whether to drive the car forward. Next couple sessions, there's some flexibility on this. Finish gathering the history, explaining it in more depth. And very important, you're setting the parameters or the treatment expectations. The way I look at that is like a perimeter. So parameter and perimeter comes to mind. And so you're setting a safe boundary around the treatment, a safe frame, and telling them, well, these are the boundaries, but within this perimeter, within those boundaries, I want you to feel free to truly be yourself and to bring up whatever's on your mind, that this seems to be a place that's really just for you and feels like that's just for you, and that you don't have to worry about my judging what you're going to say or that there's a right thing or wrong thing to bring up. Whatever you would like to bring up within the parameters we set, is fine. Then discuss other adjuncts. So meds can sometimes be helpful. Often we need some reframing around that. They may have been told that they're bipolar and they're not really bipolar, but many of them come in with the expectation that meds are going to really solve their problem, and this is just to help the medications along. So we need to kind of reframe that. The medications can take the edge off things, but most of our patients have been on multiple medication trials already, and typically they either get side effects or they work for a while, then stop working, or they have a partial response, and they tend to accumulate medications over time. So it's not unusual for them to come to us on 3 to 5 different meds. So meds may play a role, but it's limited, and we know that from research, small effect size for medications. Group therapy, we do recommend that they be in some kind of adjunctive group at the same time. For people with addictions, we recommend a 12-step groups that they be involved in that. We also recommend DBT skills group. There's also SCT, system-centered therapy, that Dr. Anil does, which is kind of an interpersonal group. So in fact, only about a quarter of our clients agree to be part of a group, but we do recommend that as an adjunct. Employment, what we have generally found works best is part-time employment. So even if that's a volunteer job, it doesn't have to be paid employment, but having that structure to their day, having a forum for interacting with other people provides material for them to explore and learn more about themselves, having a schedule that they need to stick to. So having a part-time employment can be helpful. And for many of those, it is a volunteer employment and volunteer employment is a great way of getting started. And then asking for a commitment to 1 year. So again, it's all part of the process of individuated relatedness. So it becomes their decision, they're taking responsibility for the treatment and making that commitment. So we'll tease apart these in a little bit more depth here. The chief complaint, I talked about this in the small group, the chief complaint is actually very, very important. Again, it's to get the client to take ownership for what they want, not what someone else wants, but what do they want out of treatment? What are they hoping to get to at the end? For some clients, it actually takes a lot of effort to work with them to come up with a chief complaint. And you can go over, different symptoms, borderline personality disorder. Are these things, these are things you currently have. Are these things you want to get better? You can look at their, amount of depression. Is that something you want to get better? So to come out with a chief complaint, though, because later on in treatment, when you're in guilt preparatory state and they're totally ambivalent or stage 3 about whether they want to continue, you can go back, well, this is what you wanted out of treatment. And if you still want that out of treatment, this is what it's going to take. I like to look at the themes and patterns of previous relationships, especially actually former treatment relationships. So what did you guys talk about and work on? How did it end? Because you can bet dollars to donuts, whatever pattern, whatever problem they ran into there is going to emerge in your relationship as well. So they felt maybe not listened to, they felt controlled, they felt therapist was too passive, whatever it is, it's going to come up, and that will give you a big clue to what to watch out for as you begin treatment. Ask specifically about a whole host of self-damaging behaviors, because there's a lot of avoidance, and our clients are generally ashamed of these, and I know some of them have it in your face all the time, but a lot of them won't talk about it, and so you need to actually bring it up periodically in treatment. Have you been drinking lately? Or especially if you see them kind of going downhill a bit, to actually ask about some of these behaviors as you go along to see if they're getting better or worse. You do want to assess risk. And I do recommend, we do this with all our clients, some screening measure for borderline personality disorder. And one of those is in your handout, one that was developed at Upstate called the UBQ, Upstate Borderline Questionnaire. And very short, but you then have some objective measure that can alert you to the presence of this disorder. So generally the way I structure the first session, I spend 90 minutes on the first session. You may or may not have that luxury, but if it's a 90-minute session, the first hour will be getting the history, and then I'll start I'll try to formulate the case and bring in what the clients told me, and then ask them if that makes sense to them, and whether they want to give this treatment a try. And here is an example. In the manual, I have other examples, the addicted client or those who are med seeking. But here's a common formulation I might present. You seem to be stuck in a rut. You're experiencing chronic depression, feelings of emptiness inside, and are coping by drinking a lot. I noticed in the interview that you had difficulty describing some of your experiences and knowing exactly what you were feeling at any given time. When people are out of touch with their experiences, it can lead to feelings of emptiness, confusion, and lack of sense of self. The goal of this therapy is to help you become more aware of different parts of yourself, start to figure out who you are, and work towards self-acceptance. You'll find this very difficult since your main coping up to now has been to numb your emotions and avoid experiences by shutting down your brain with alcohol. And treatment with DDP does just the opposite. It involves exploring and getting in touch with your emotions and experiences. Often a useful emphasis is to talk about recent interactions you've had with other people, or you may find it helpful to explore your dreams or some kind of creative work like poetry or art or, with me. And through this process, you may find that a more positive, complete, and secure self starts to emerge. Does this sound like something you'd like to try? So this can, I don't recommend using it verbatim. I think you need to find your own words based on what you understood from this workshop. And then ask, something that makes sense to you and something, because if it makes sense to you, it has a higher likelihood of making sense to the client. And then asking if it's something you'd like to try. So what I did is include a number of forms in your handout too. There's a lot of paperwork involved when I start with a new client. So before they even come to see me, in fact, I have them fill out some outcome questionnaires. So I don't have those on here, but I then give the outcome questionnaires every 6 months. That gives me a stronger position to say, yes, you actually are improving in these areas, but not in these. It actually provides some objective measure of whether people are getting better. But I also give, as I said, a screening questionnaire, and feel free to use that. The Upstate borderline questionnaire. I also do video record every client, and you can see the example of the release for video recording that I have, and that allows me to, and I'll talk to the clients about it and what I use it for, and sometimes I'll use it for consultation if I feel I'm getting stuck. I sometimes use it for teaching purposes in a disguised form. As you can see, I use a disguised form. And then I also hand out at the end of the session too an information sheet on borderline personality disorder, and tried talking to them about that diagnosis if they haven't been assigned that diagnosis in the past. Generally, clients receive that pretty well. It has more stigma for us as therapists, I think, because of the button pushing than it does for the clients. And when they look it up on the internet, it often makes a lot of sense to them. They say, oh, that is me. The problem is when they go look at it on the internet, there are some very negative websites too. Sometimes family members will put together websites which are not very complimentary to this disorder. So they have to be a little cautious about what websites they go to. And the sheet actually has some recommended websites that they can go to as well. And then the treatment expectations and the daily connection sheet are also in your handouts. So, and this is the treatment expectations I use. So come to sessions on time, pay your co-pays at the time of each visit. And the rationale I provide is that, these things help me from getting burned out. And if I'm burned out, I'm no longer going to be as available to you and as helpful to you. So the reason we have these, and I'll tell this to the client, the reason we have these expectations is not to find ways of kicking you out of treatment. These are the minimum expectations that I need to be helpful to you. So actively participate in treatment. So it's not the kind of, this is the rationale I'll use, it's not the kind of treatment where you can sit back and say, cure me. It's going to need active participation on your part. You're going to need to bring up recent interactions you've had, or behaviors you've been struggling with, or some creative endeavor, or a dream, but you need to be an active participant. And then the video recording and completing questionnaires is part of what I need for quality assurance to know that I'm on track. And also, since I'm a faculty member, teaching is really important for me. to do, but if I do take a clip, I will use a disguise form and am very careful about that. And 5, limit phone calls to twice a week. And the reason I limit it is just so that I don't get burned out, because I find for myself that it's more than twice a week I start getting burned out. But within that limit, I want you to feel free to use those calls, if you just need to check in and or reschedule or whatever it is. So I found that I can't really do therapy on the phone. This is what I tell the client. I'm just role-playing here. I can't really do therapy on the phone. I found that really doesn't work very well, but in terms of just checking in, we could do that. Now for you, it doesn't have to be twice a week, whatever you feel comfortable with without getting burned out. So you need to know your own limits on this. And maybe it's none, maybe it's no phone calls, but twice a week is my limit. And then 6, very importantly, keep yourself safe during treatment. So this means, I know part of you has said you really don't care and want to die, but I'm not a Dr. Kevorkian. I'm not here to see you in completed suicide. I'm here to see you into recovery, and I would love to be part of that, and I hope you are interested in working towards recovery, but I can only work with you if you really decide that you're going to commit with that part of you that does want to recover. You wouldn't be here if part of you didn't, and but really commit to trying to keep yourself safe during this process and take responsibility for that, so that if you do need to go in the hospital, if you feel your suicidal impulses are out of control, you'll get yourself there. It means that if your doctor is prescribing medications, that you take them as prescribed. And then if you need appropriate medical care, let's say you're cutting too deeply, or if you have a lot of purging behavior, which can be potentially dangerous, that you obtain the appropriate medical care. And by the way, for persons with eating disorders, if they have severe eating disorders, I do require certain things. Require that they maintain a level above a certain weight. Require, it's part of taking care of yourself, and require that they get a primary care physician, get regular checkups for electrolytes. And then no hostile behaviors, including profanity, lying, verbal threats, or physical threats. Notice profanity is a pretty low bar, right? I mean, it doesn't seem that hostile, but as Dr. Mustad is saying, if you can correct if you can point out and stop the hostile behaviors when they're at a small degree, you'll find then that they won't escalate into more and more. If you don't put a containment on hostile behaviors, especially with the more antisocial, they'll keep testing and keep escalating to more dangerous kinds of behaviors. So that's session 1. Session 2 and 3 or 4, you finish gathering the history. You're explaining the treatment more in depth. I do give them the daily connection sheet, not as homework, but this is something we encourage. You can find helpful. In fact, many clients find it's helpful to bring them to session because it reminds them of what happened in the week. So as an aside, because of the avoidance, many clients come in and they just can't remember what went on that week. They've suppressed it all. And so the daily connection sheets helps them to continue the process of staying connected and to make better use of treatment when they get to your session. Then it's session 2 that I'll give them the written treatment expectations, not in session 1, and go over the rationale in the same way I did with you. I give them a sheet. I don't have them sign anything. That's too formal, but I do give them the sheet and save one for the chart. And then discuss these other issues. I have a question mark meet with the family. I don't do family therapy at the same time that I'm seeing an individual client for DEP, because I do want, you remember, fostering individuated relatedness. I do want the client to feel this is a place just for them. But if the client is living at home and is a young adult or teenager living at home, I will meet with the family usually in the second or third or fourth session, so early on in the treatment, to let them know about what the treatment involves and that I won't be able to have much contact with them except in an emergency because I do want this to be a place that's just for them, for the client. But I do also refer them, if they're interested in family therapy, I will refer them to a family therapist to do that work. And then asking again, so I do that session 1, and then after going through all this, I'll ask again whether the client is interested in doing this and can agree to keeping the treatment expectations and commit to 12 months of treatment. And I will tell them, that 90% of people who finish the treatment will get significant improvement. So, stage 1 is, can I be safe here? And they're testing 3 safety concerns. Does the therapist care about me? Will the therapist respect my opinions and choices? And will the therapist keep good boundaries and prevent my neediness and rage from destroying the treatment? So the containment. So caring, respect, and containment are all tested out in stage 1. So, right from the beginning, I'll ask, what would you like to share today? I don't like asking, how are you? Because it sets up a certain frame. It sets you in the driver's seat saying, I'll take care of you. Where would you like to go? Instead, it's up to the client. You're giving them the responsibility for what they want to bring up. So what would you like to share today? What would you like to bring up today? I don't know. I don't know how to drive. So, early on, I'll just go over again the information. Really, whatever you'd like to bring up is fine. I want this to be a place where I'm not asking the questions, and because I want this to be a place where you feel like you can ask what you'd like to ask and bring up what you want to bring up. This is your I want this to be your treatment rather than my treatment. Or the client may ask, I don't think I can control my suicidal thoughts anymore, but I'm not going to the hospital. So this is another example of testing. Because on the one hand, if you say, okay, it's up to you, you're conveying uncaring, right? You're not being the caring therapist, and you're not being containing. You're not containing them. On the other hand, if you involuntarily take them to the hospital, then you're undermining their autonomy and being disrespectful. So it's kind of a catch-22 kind of trap. And there's, let's see, what do I say there? So really the best answer to that is to just say that. On the one hand, if I don't admit you, I'm going to come across as uncaring, uncontaining, and you have a need for that. On the other hand, if I do, I'm worried that, it's going to jeopardize our relationship because it'll seem very disrespectful. So I'll just outline the dilemma to them and see what they do with it. And ultimately, of course, we need to hospitalize if they can't assure you of safety. So there are ideal other techniques, and I think all of you are probably pretty good at this already. Empathy, warmth, responsiveness. Kindly questioning emotions in the moment is actually one of the most important, effective. Very often, clients will cry in the course of session, and we have to be very careful about making assumption what those tears mean. Sometimes people cry when they're angry, sometimes when they're overwhelmed and confused, sometimes when they're sad. It's usually not when they're sad. But when you see a lot of emotion, just stop whatever you're doing and say, I notice you're really upset right now. What's going on? And what that does is really, it really builds the alliance enormously. It means that you're responsive. It's not your agenda that you're going to impose. You're really responding to where the client's at that moment. And you begin the process of labeling emotions right at the beginning in the here and now. Containment, and that's all the things with containment are the boundaries. They're part of individuated relatedness. So clear expectations, providing a lot of information to them, inquiring about, you want to check in with them about things like this. Keeping boundaries around physical contact or sharing personal information. We avoid focusing early on in childhood trauma. We talked about that yesterday. And also avoid a major focus on physical symptoms or side effects. So they may start with that, and I'll say, that is important, but let's save that for the end. So that's containment. And then respect, we talked about all the ways that you can support individuated relatedness. And I want to go back to my favorite pseudo-narrative from yesterday, and just want to ask you, what if your client says this? I get so sick of people coming to me for advice when my friends are talking about what jerks their boyfriends are and how unfair their parents are. I keep thinking about suicide because no one around me thinks I'm going through anything at all. How would you foster individuated relatedness here? So we talked about how to build a narrative, right? Let's say that you feel that something, though, is going on in the client-therapist relationship. So let me actually first go over the other two interventions. Intervention one, you'd ask, well, can you give me a specific example, right? And then build a narrative. Intervention two is you'd ask about alternative attributions. So, does part of you feel also gratified about people coming to you for advice? I notice you're saying that people are minimizing what you're going through. Do you sometimes not take yourself seriously? Do you sometimes minimize it for yourself? Okay, so that's a way of opening up the attributions. How would you foster individuated relatedness? Anyone want to take a crack at that? Yeah, good for you. Brave soul.
Since they say no one around me thinks I'm going through anything at all, would you say something along the lines of, do you feel sometimes that includes me? Like I don't think
Perfect. Very good. Very good. Yeah, brave to volunteer that, and that's exactly right. So you bring it back into the client-therapist relationship. Do you sometimes feel that I also minimize what you're going through? Absolutely. Most of the time the answer is yes. Client may or may not volunteer that, but usually if they're talking about everyone else doing something bad to them, usually that includes you. So, wrapping up here, levels of competency are basic, advanced, and master's level. So basic means that you have some basic understanding, and as long as you get case consultation ongoing, you can apply DDP pretty competently on your own, competently with some help. Advanced means that you can practice independently, and also having advanced level means that you're able to certify others at an advanced level. And then a master's level means that you've had extensive experience and training, training others, as well as extensive clinical experience with the technique, and then you're able to certify others at a master's level. So steps to advanced competency, for those of you who are interested in doing that, you need to read the manual, work through the interactive module, and then get weekly case consultation while you're treating clients in a DDP model. And to reach an advanced level, you have to bring at least 2 clients through all 4 stages of recovery, then to get certified at that level.